In part one of this series on system concepts, we heard Dr. Akoff give a wonderful explanation of what a system is. In part two, we explored the systems thinking principle that helps us understand why having all of the best individual parts needed for a system does not necessarily get us the best system. That's because the performance of a system is not the sum of its parts, it's a product of their interactions. The parts all have to fit together well. In part three, we found that even with great parts that fit together well, you still may not have the best performing system. We explored the definition and calculation of value. We saw how the value equation uses measures of quality and cost to calculate value in a quantitative way. The best systems of care provide high quality as measured in outcomes, and the best systems are able to do so at a low total cost as measured in dollars. High quality combined with low total cost provides the best value, and that's what the best of the best systems of care deliver. Here in part four, we're going to revisit the systems of care concept itself and dig a bit deeper, specifically in the context of Hrt-C conditions. Hrt-C is the acronym we will be using here for high-risk, time-sensitive conditions. Now, a system of care for acute ischemic strokes, for example, is a true system as described by Dr. Akoff. Its primary purpose, like the other systems of care for Hrt-Cs, is to restore pre-event health status. But a comprehensive stroke system of care will not just try to quickly reopen the obstructed vessel. It will also seek to address the challenges of rapid recognition of an acute onset stroke by patients and bystanders, get them to seek immediate medical care, preferably via 911, provide protocol guidance for the EMS response to include stroke screening, and if a stroke is suspected, to do a severity assessment for identification of likely large vessel obstruction cases. Then guide decisions about the most appropriate destination hospital. Effectively communicate findings from the field to the receiving hospital. Have the hospital stroke team activated prior to ambulance arrival. Consider routing the patient directly to the CT scanner upon hospital arrival to save more time if it's appropriate to do so. Then make the appropriate decision about acute treatment with thrombolytics and/or mechanical thrombectomy. Provide any other supportive care as needed after restoring flow, and then provide rehabilitative services to address any neurological deficits that may have developed. That stroke system of care scenario involves lots of different providers. Organizations that provide public education on stroke recognition and accessing the 911 emergency response system. The primary 911 communication centers, which are typically operated by law enforcement agencies. The secondary 911 communication centers used for emergency vehicle dispatch at the fire departments and/or the ambulance services. Non-transport medical first response, often operated by the fire department or other rescue squad organizations. The ambulance service itself, the emergency department, the stroke service of the hospital, radiology department, hospital laboratory, hospital pharmacy, in-house rehabilitation services, and the discharge planning service, not to mention all of the ancillary support services that contribute to care. As a true system, all of those parts are needed to constitute the entirety of the stroke system of care. Some even extend the bounds of their system of care activities to address secondary objectives of preventing the stroke from happening in the first place with primordial and primary prevention efforts on the front end, and another secondary objective for prevention of subsequent strokes via secondary prevention on the back end. If pre-event health status cannot be fully restored, there may also be a secondary objective of providing the best quality of life possible through long-term care, and that's also part of the stroke system of care. In any case, there's lots of different organizations, lots of different teams and functions within those organizations, lots of handoffs, lots of communications needs, and lots of opportunities to do each part well and connect it to the next part well. Or not so well. That's why the design, operation, and improvement of our systems of care needs to address the whole system of care. To do that well, we need to find ways to measure how well the overall system of care is performing in terms of quality, cost, and value, then apply quality assurance, quality improvement, and research methodologies to continuously seek out ways to elevate systems of care performance over time. Systems of care, it's a big issue. It needs more attention. We need to look outside of our stovepipes and see the bigger picture. I hope this helps wipe some of the bugs and grime off your windshield so this bigger picture of systems can come into better focus.